Welcome back. South Korea's daily COVID-19 tally has been hovering above the 100,000 mark amid this latest rebound in infections. And today, we revisit efforts to address the pandemic with a panel of health experts. I have Professor Jung Ki-suck from Hallym University, who is also heading the National Infectious Disease Consulting Committee. Professor Jung, welcome back.
Good afternoon.
I also have Professor Howard Lee from Seoul National University. Professor Lee, it's a pleasure again.
Thank you for having me back.
Right, Professor Chung, we'll start with you then. Health authorities have spoken about keeping their strategy focused on addressing critical cases to prevent fatalities. What are your thoughts on their efforts thus far?
Well, government is heading for a right direction because if you can decrease the critical cases, then automatically you can decrease the fatality cases. So there are some high-risk groups who can easily get COVID-19 and get into critical cases. Those are aged 60 and over, and regardless of age, who have chronic diseases or immune-compromised status. So there are some measures to prevent those high-risk groups get into a critically ill status and get into fatal cases. First of all, the fourth vaccination. So almost all high-risk group had already got a third vaccination, and we need a fourth vaccination for them because that kind of fourth, in other words, a second booster can reduce the mortality and critically ill cases by 50%. And another armament is antiviral agent, so-called Paxlovid, Lagevrio, and Remdesivir. If you can put those agents as early as possible, you can reduce again by the 50% of mortality cases. And on top of that, the government is preparing a sufficient number of emergency room and ICUs. So by doing that, I hope that we can reduce the case fatalities on high-risk group, and as a result, you can see a very low case fatality rate with COVID-19.
Right. And Professor Lee, staying with the government's COVID-19 strategy, approval has been granted to a new COVID-19 medication called EVUSHELD. Could you tell us a bit more about this particular I think it's a preventive medication, right?
That's true. EVU or EVUSHELD is an interesting pre-exposure prophylaxis. So this is not for treatment, but for prevention. It contains two long-acting monoclonal antibodies targeting at the spike protein of the COVID-19 virus, which is critical for the virus to enter into human cells. Many people, like Sunny, you and myself, do not need EVUSHELD. We need vaccines instead. But there are some people who need EVUSHELD. For those who are not expected to mount an adequate amount of immune response, those people are likely to have some kind of immune suppressive medications, or they underwent some kind of immune compromised situations. Or somebody who have been showing some kind of hypersensitivity reaction to the vaccine. EVUSHELD is needed for those kind of people. EVUSHELD, however, is contraindicated or should not be used for those who were allergic to any component of EVUSHELD, or it can show some kind of cross-high sensitivity with COVID-19 vaccine. Also, it is injected intramuscularly, so if you have blood clotting sort of disease, and then you are not indicated for that. And also, the study shows that if you are on EVUSHELD, and also you have risk for cardiac diseases, cardiovascular outcomes are much higher. So in that case, you shouldn't receive EVUSHELD.
Right, I see. And Professor Chung, on the topic of medication, do we have an adequate supply of COVID-19 treatment amid this latest surge in transmissions? And with regard to treatment about using Paxlovid, has South Korea witnessed any rebound cases following this particular regimen, that is Paxlovid?
Yes, that's a very interesting question. We have 1 million doses already in Korea, and about 300,000 are already consumed. And we are going to have another 1 million doses contracted, and they'll be coming by the end of this year or early next year. So, so far I think it's sufficient, but if you have a large research in coming fall or winter, then we have to change the plan. Regarding Paxlovid rebound, it's quite interesting one. It's not a new one. Rebound means rebounding of a virus and or rebounding of a symptom. So it isn't, the Pfizer says it's the prevalence of 1 to 2% of our population. And it was found from the beginning of a clinical trial. So at the clinical trial, that's so. In the Paxlovid group and the placebo group, the same amount of rebound was found, 1 to 2% of rebound, either a virus or a symptom. And still we are seeing 1 to 2% of that kind of rebound in the United States. But luckily, here in Korea, we already consumed nearly 300,000 Paxlovid here, but we do not see any kind of rebound. But I don't think it's a bad one. This is a kind of a natural one because virus comes and goes during a certain period, and symptom comes and goes during a certain period. I don't think it's a big deal.
Right, it's not anything for us to worry about too much then.
Right.
Professor Lee, prior to this latest wave of COVID-19 here, there was much talk about Omicron-tailored vaccines being available very soon. What is the latest on that front?
Well, a couple of days ago, Pfizer and BNT announced that Omicron-targeted or Omicron-tailored vaccine is going to be available as soon as early October this year. And they are embarking on a new clinical trial for a new vaccine targeted Omicron variant. It includes both the old one, BA1, and the new one, BA4 and 5. So hopefully by the end of September, they will get some clinical data. And actually, Moderna is following the same route of developing bivalent vaccine. And according, if I'm not seriously mistaken, Pfizer and BNT has completed a trial with the monovalent against Omicron BA1 vaccine trial, and then they have submitted the data to the regulatory agency. So pending approval by the FDA and EMA, Pfizer and Moderna will be able to roll out the Omicron targeted or tailored, if you will, vaccines by the fourth quarter, as early as October this year.
Right. Meanwhile, Professor Jung, reinfection appears to be rampant amid the resurgence of COVID-19. Now, that being said, how common is reinfection here on the local front?
From the beginning of a pandemic so far, the overall reinfection rate is still lower than 1%. It's 1.79%, very low. But these days, last week, KDCA reported the reinfection rate is 5.4%. It's quite increasing. We know the reason why, because the BA5 is evading immunity, which already made by a BA1 or a previous Delta. And if you break down the reinfected people, you can find that half of the reinfected people are aged below 18, the younger ones. The reason is because quite many of those group had not got a vaccination, because below 5 years old, you don't have any vaccine available. And between 5 and 17, many students and children didn't get a vaccine. So another finding is, regardless of age, if you do not have a vaccine, if you didn't get vaccinated, then you have a better chance of a reinfection. So vaccine is again the most important in preventing reinfection. But unfortunately, these days we are seeing a mild increase of gradual increase of reinfection, and maybe like other developed countries, maybe we'll see a 10% or maybe 20%. In other countries, since the reinfection rate is very high.
Is there a way of dealing with that particular reality then? Should we be encouraging more of our younger children to get vaccinations then?
Yes, particularly very high-risk patients who are obese, who have a chronic disease like diabetes, and chronic kidney disease, they should get vaccinated.
Right, I see. Professor Lee, where does South Korea stand in terms of developing perhaps a treatment option for COVID-19?
As of today, there is only one treatment option available, approved by the regulatory agency in South Korea, Rakiron by Celltrion. But the role of Rakiron in the treatment of COVID-19 has vanished almost since it did not show efficacy against the Omicron variants. That said, however, another Korean company is currently developing an antiviral treatment in collaboration with a Japanese company, Shionogi, and the name of the drug is Jocova, and Jocova is basically working according to the same by the same mechanism of action as Pfizer's Paxlovid. It's a protease inhibitor. That said, however, the first attempt to get that drug approved or emergency use authorized by the Japanese government has failed. So the jury is still out.
I see. And given the current state of affairs, Professor Lee, I understand this might be a tricky question, but what do you believe is more productive, the development of treatment options or that of vaccines?
Well, that's a very tough question to answer. Both are important, but if I have to choose just one, I would say vaccine development at this point is treatment development is slightly more productive at this time of moment. The reason is because vaccine has to be specific to the target antigen. But as we have witnessed so far, the virus has been evolving continuously by changing its target antigen. So vaccine development in this kind of situation is a perpetual game. And I don't think that kind of catch-up is going to work forever.
Right, I see. And Professor Jung, here's another tricky question for you then. When do you predict will South Korea's current wave peak?
Well, several mathematical models anticipated it by the mid of August, and by the end of August, they will see a peak. The volume will be about 150,000 to 200,000. But it's just kind of guess. Nobody knows because we are still chasing a BA 2.75, and still the BA5 is increasing, not comprising 100%. So nobody knows. But I don't think the volume is the figure is important, but the more important is the severity. Even though you have more number, if you have a lower severity, lower case fatality, then you cannot worry too much about that. So I think the severity is more important than the plain number.
Right. And Professor Jung, do you expect another resurgence in the winter?
Sure. If you recollect the previous winter, we had a big surge last winter, and 2 years ago we had the third wave again. So because the COVID-19 virus is a respiratory virus, and respiratory viruses are proliferating during winter time, it's a fact. And on top of that, we have waning immunity among whole population. The fourth vaccine, once I emphasized, it began as early as end of February. And by April, the 60 and over started the fourth vaccination. In July, government pushed some disabled people and the people who are living in long-term care facilities. So altogether, they will lose the immunity by the November or late early winter. So in that case, most people will have a lower immunity. And we had the Omicron surge at peak March. And if you have immunity by natural immunity, which is got by infection, it only lasts 4 or 6 months. So again, by the October and November, the infected people who have a natural immunity will lose immunity. So the lowest immunity will be coming in the late fall or early winter. So that's why I'm emphasizing getting a vaccination, the new kind of bivalent vaccine as early as possible, maybe early October or late November then we can do better with that kind of vaccine.
Right. And in the meantime then, Professor Lee, the academic arena here in the country is opening its doors this month. What do you propose to ensure safety at schools?
The time of peak resurgence is expected to coincide with the time of school reopening at the end of this month, August. As Professor Jung has already mentioned, what makes the matter more worrisome is the fact that only less than 1% of children under 12 have been vaccinated. I think the recent statistic, as Professor already mentioned, almost 1/3 of reinfected cases happened in children under 17. So, having said that, I think we have to think about the way that we can encourage the parents to bring their kids to the clinic for vaccination. And this is kind of a tricky thing. And more or less, it is something that needs to be approached by a behavioral sort of aspect of practice. That is something that we need to seriously consider, and that has been taken into account. But in the meantime, students suspicious of any COVID-19 symptoms have get their rapid antigen test available, and also wearing a face mask is a mandate, of course.
Right, within the classrooms, of course.
Yeah.
Professor Jung, speaking to the local media this week, you claimed an endemic phase of COVID-19 will be possible if we better protect our vulnerable groups. Would you like to take this opportunity to elaborate?
Well, yeah. I anticipated a stable endemic condition maybe as early as next spring. Because endemic means you can anticipate, you can predict the amount of the volume of infection, and the infection will be stably controlled, and etc. If we are doing better with the high-risk groups, I mean, the high-risk group comprises over 90% of all fatality. And people who are living in long-term care facilities like nursing home, nursing hospitals, psychiatric institute, and etc., they are comprising 1/3 of mortality cases. So if you focus on those high-risk people and diagnose as early as possible and get them medicated with the Paxlovid, Lagevrio, and etc. as early as possible, then you can reduce the mortality. And also with fourth vaccination and consecutive vaccination. So you can reduce mortality by 50% with the fourth vaccine or fifth vaccine, probably. And you can reduce another 50% of mortality by antiviral agent. Then you might see a total case fatality nearly approaching influenza. The influenza case fatality is 0.02% to 0.03%. These days we are seeing a 0.04% of COVID-19 fatality these days. So if you halve the case fatality, then you can make 0.02%, which is very similar to influenza. Then if you have, we feel very safe with that kind of a figure. It's like influenza. You can get diagnosed as early as possible. If you are very ill, you can get an antiviral agent. So in that case, most people live their ordinary lives without worrying too much about COVID-19.
Would that also mean no face masks indoors?
Maybe next spring.
Right, I see. And beyond COVID-19, Professor Lee, the recent record rainfall here in the country has triggered much concerns about waterborne diseases. Could you tell us more about them and ways to prevent ourselves from them?
Well, high humidity can cause several diseases to occur or aggravate the symptoms of existing diseases. It is because humidity provides a condition where the microorganisms such as fungus and bacteria can grow faster and wilder. The good example is athlete's foot or the ringworm disease of the foot. But that's not the only disease that can be aggravated or aggravated by high humidity. Asthma, atopy, allergic dermatitis can be also aggravated. And also high humidity in the high humid condition, microorganisms can enter more easily into the subground water, and that's why we have to worry about more foodborne or waterborne infection at this point.
All right, so we need to be very careful then.
Yeah.
All right, Professor Lee, as always, thank you very much for your time
Thank
and your thoughts. And Professor Jung, thank you very much for your insights.
Thank you.